The reasons why I started doing training on working with survivors of sexual violence and specifically survivors of any type of interpersonal violence and trauma. I work with survivors of domestic violence, child sexual abuse, and sexual assault in my private practice and in the rape crisis centers for about the last 14 years. And one of the first things that I did in my undergrad is I was working as an intern at a locked psychiatric facility, and because I was a dual bachelor's women's studies and psychology major, I decided I'll run a women's group at the psychiatric facility. And when I hung the flyers and everyone showed up for the first day of group, what I recognized in a few moments of introductions to the group was that this group of women who had shown up to come to the women's group who had histories anywhere from 5 to 25 years of being housed in different mental health, psychiatric locked settings and going to partial hospitalization programs. Some of them had been in homeless shelters, in domestic violence shelters. They had, been through, SART and those sorts of things. That most of them talked about the fact that they really hadn't ever had a chance to talk about all of the violations that had occurred in their life, because what had always been focused on was the severe symptoms of the other psychiatric and mental health disabilities that they had, that had been the focus, that had become who they were. And so here they were with lots of time in many different social service and mental health organizations, even being housed there, but every single person in that room, every single woman who had shown up was a survivor often of child sexual abuse, a rape in teen or adulthood, and intimate partner violence at some point. And so we started a group that was a pretty intense process. And for me, what it solidified was that in order for me to specialize in working specifically with survivors of violence, that I also needed to make sure that I understood how people walked in the world in terms of dealing with psychiatric and mental health disabilities. So that's my goal today, is to clear up some of the myths around that, to hope that we can start to maybe use some of the ways of not compartmentalizing some of our services so much, and to clear up some of those misperceptions about the ways that someone who has psychiatric or mental health disabilities may come forward and tell us about the abuse or violence they're experiencing in their lives. I'll probably put it in the form of speaking about sexual violence, but I really think it applies whether we're working with child abuse survivors or intimate partner violence survivors, and also speak to how we can be first responders. What are some of the things that we can do in order to gain that alliance and trust as to get a full disclosure, and also looking at how, if we're doing longer term services for survivors with mental illness, how we can make those services work a little bit better, because there's a lot of overlap, and sometimes we start again to look at all of these diagnoses and all of the symptoms that folks are having, and I'll be speaking more towards the severe end of the psychiatric disorders in terms of someone whose functioning is really becoming impaired by the level of symptomology they're experiencing. One of the reasons also for talking about this is because we often miss the fact that in the statistics, and I think some of the research is at the low end, says that folks specifically with mental health disabilities or any psychiatric symptoms are at about 2 to 10 times the rate in terms of risk for being sexually assaulted in their lives. We know in general folks with any sort of disability are at a much higher rate of being sexually assaulted, also at a much higher rate for domestic violence and intimate partner violence, and that is a big piece of looking at how those aspects of being someone who is using psychiatric medications or needs to go to case management or day treatment, that partners who are abusive are going to often wreak havoc with all of those things that would actually help in the healing process. So in terms of looking at these things, a few things I want to say is that I do want to kind of distinguish this from any sort of developmental or intellectual disability in terms of developmental delays. A lot of times we hear things, and I know sometimes in cross-referring and collaboration, someone will say, well, this person is mentally challenged. Well, what does that really mean? And in fact, I'm really adamant about utilizing and echoing the words that the survivor tells me about their experience. So if they identify as a consumer, then I use the term consumer. If they identify as having a psychiatric disability, I use that terminology. If someone says, here's my diagnosis, I'm bipolar with psychotic features, and this is what meds I'm on, that is what the language I'm going to use. And that's one way right off the bat that we can show someone that we are respectful, right? That we're not going to label, but they get to self-identify. And I think that's very, very important in making that connection. The other reason for not using kind of things like slow or mentally impaired or mentally challenged, or even just saying mental disability, is that the way that we accommodate intellectual or developmental disabilities is very different from how we need to accommodate someone that has a psychiatric or mental health disability. So in introducing a survivor that way, maybe to a collaborative or to a referral that we're giving, we may introduce a situation where someone isn't going to get the proper accommodations. And really, we don't know what accommodations someone needs. And when I talk about accommodations, I mean those reasonable things that we can do to make sure that we're not providing, what we call equal, but cookie cutter, but equitable services, right? We're meeting each survivor with the needs that they have where they are and making those accommodations for any folks that have disabilities. So I just wanted to make that distinction. The other distinction is that I will be talking about survivors and not perpetrators. According to the folks in terms of Center for Sex Offender Management and Anna Salter, most perpetrators, only about 2 to 5% have any psychiatric symptoms or disabilities. So it is it's really rare, even though we'd like to say, well, someone who'd rape an infant must be, crazy. There must be something wrong. We know that this is a choice, and so I won't be speaking about perpetrators, but a lot of times when I start to talk about folks having psychiatric symptoms and things like that, the assumption is, oh, I'm talking about the offenders, but I will be talking about survivors. So I do want to just have us think about how trauma and other psychiatric symptoms interact, right? Because of course, acute stress disorder or post-traumatic stress disorder are mental health diagnoses that we find in the DSM. But talking about that comorbidity, right? When we're seeing both, we're seeing that someone is the survivor of often intense and profound trauma. What we see for folks with disabilities is that 2 to 10 times as high rate is also increased by the fact that you see multiple perpetrators and multiple violations and abuses across the lifespan. So that is making that number go up incredibly, at a high rate. And so when we look at how trauma and other psychiatric disabilities interact, it is kind of that chicken and egg thing that we don't know what really came first. And then if you throw in the use of drugs or alcohol or other things to try to self-medicate and deal with the mental health symptoms or try to deal with the pain of the abuse, you've got another piece in the mix. And we'll talk a little bit about that briefly. We could have another day on that. So I just want to go through some of the ways that we can start to think about how many skills all of us in this room already have. If we're here because we work in or care about or volunteer with organizations where we are in contact with survivors of trauma and abuse, we already have a set of skills for working with folks with psychiatric disabilities, and we may not even know that. So when we think about depression, and what I'm going to do is really give us kind of, I hope, a new way of looking at how some of the things we might see in terms of psychiatric symptoms really overlap with trauma, and that we have to be careful of sort of immediately believing, well, that's a mental health symptom that I don't work with. I'm here to deal with the domestic violence, I'm here to deal with the rape, I'm here to deal with the child abuse issues. And to show us that we already have some insight into that. So when we look at depression, for instance, and maybe we're working with someone who's had long-term clinical depression, one of the things that we want to think about is how much, right, that's a part of trauma, that our worldview changes, that being the survivor of interpersonal violence says to us, well, maybe I didn't understand the way the world works. Or from the very beginning of that development of how the world works, can I trust people? Will my needs be met? That's already become a no, because those earliest incidences and experiences of abuse and trauma have already been there. And we see this in personality disorders, and we also see this in dissociation. So oftentimes the folks who kind of are at that end of the spectrum was like, oh, I don't want to work with people with personality disorders, or that client's so resistant, they're so difficult. And also when folks have alters, when the abuse has been so severe, and I see dissociation on that spectrum, everything from kind of numbing out or spacing out or leaving one's body not to be present when abuse is happening, all the way through then dissociating to the point where there's alters. Those are pieces of that loss of a sense of a solid self, right? That we should have that nurturing, loving environment, every person, to develop a solid sense of self, and how much that will impact relationships and how we move in the world. And so really when we're working on the ways that trauma has impacted a sense of self, feeling capable, feeling lovable, feeling as though other people will be able to see that in us, not the sense that, well, if anyone knew who I really was, everyone would know I'm a bad person and I wouldn't ever be loved again, which we know a lot of the survivors that we work with feel that way, or you may have personally been through that. The overwhelming sadness and grief oftentimes, look like what we call those negative symptoms, for instance, of psychotic disorders, where we really do have to discern whether, if these symptoms are so severe that it's a place where, keeping up hygiene or getting out of bed in the morning is difficult, and that can be a part of trauma as well, right? So some of the ways that we are working with folks can be very similar. The sense of abandonment and isolation, and I think this is very real for both groups, especially when it overlaps, for survivors of violence and for folks with psychiatric symptoms. More and more that support system gets smaller and smaller, right? People get tired, get worn out, are fed up, they don't know how to help, they're tired of hearing about it, right? Even people with good intentions can say, leave it in the past, get over it, why are you still bringing this up? And that support system really dwindles for both populations. So thinking about how we can provide a way to put together that support system is huge. Also, when you're looking on the other end of mood disorders and you see that mania, one of the things I'm looking at, I work also with the California Black Women's Health Project, and one of the things we're looking at in terms of reproductive justice are the high rates with young women, and especially young women of color, of HIV infection, right? Huge. And one of the things that we see is that the impact is on high risk-taking sexual behaviors. That we know that if there has been especially childhood sexual abuse, but also then this is going to be highly impacted if you're in an intimate partner relationship where you don't have choice around how you have sex or when, and you're forced or coerced into it, that these things are really impacting the health in the long term of folks. And what we see is what can look like manic behaviors, right? High risk taking, little sleep, but also we see this in trauma, right? Staying busy as to not feel anything. And that we know that teen survivors often act out by taking a lot of risks. And so the ways that we can address that are very similar in that we don't have to be afraid that, wow, if this person is manic, then I can't deal with that. But if it's, wow, your self-care is really decreased and you're having a hard time, slowing down and dealing with your feelings, can we come up with some healthier ways to cope with that? That we can do those same things when it's called mania as we do when we see high risk-taking behaviors and staying busy and workaholism and all of those sorts of things. When we talk about looking at anxiety, one of the things that comes up a lot is, well, someone's paranoid, right? And they're having paranoid delusions. And oftentimes I find that that's said, and it's often hypervigilance, right? One of the most pervasive and one of those three sections of, what we have to have there to diagnose post-traumatic stress disorder are all of those hyper-arousal symptoms, right? That being super alert. And I know when Robert Geffner was here, he gave an amazing presentation on looking at how brain scans now are showing us that is causing an overdevelopment of those kind of fight or flight, and I always say to people, and add freeze, because that is just as reasonable and just as common, that fight, flight, or freeze part of our brain that keeps us safe is overdeveloped because you're in that tense situation, and that hypervigilance is always there for kids who are going through that, and so it actually impacts brain development. So I would ask us to say, how do we speak to people about the reasons why they may be hypervigilant, why they're on alert, why they're jumpy, why they believe that, other people might be out to hurt them, and not label these things inappropriate or irrational, right? Because even if the dangerous person or the circumstances in which they were sexually assaulted or abused in some way are gone, it's not irrational to have those things still happening in terms of the fears. When we look at obsessions, oftentimes we say, oh, okay, here's someone who's, perseverating on the same thought, and they keep asking for the same thing, and especially if we're working, in inpatient facilities, the clients that are what we call needy, that are always coming back to want more or need other services, oftentimes that obsessive kind of quality is there because that's about intrusive thoughts, right? And the trauma can really impact how much those obsessions increase, because if you're having intrusive thoughts, which we know is, that re-experiencing is part of trauma, and that folks will re-experience those thoughts again and again and again, and that fuels some of that sense of not being able to control the impulse to come back, to tell the story again. I was working at a partial hospitalization program, and they said, Tiombe, we don't know what to do with this one man in the group. He just even though we've dealt with it, he keeps talking about the abuse in childhood, and he brings it up every session, and other clients are getting really mad about it. And I said, well, that's part of processing trauma, that being able to talk about it again and again, it's a natural process for us to try to desensitize from that and to be able to talk about it. And the same thing with panic or phobias, that oftentimes panic can be part of a flashback, that we know that those traumatic memories are often stored in a place in our mind where there's no time and date stamp, right? That when that memory comes up, it is as if you were back in that moment. And it's very, very difficult to say, oh no, it's really February 14th, 2008. It's not back when this or that happened, especially if it's recent, or in anything that's associated with trauma might have that same impact. When we look at PTSD specifically, when we look at the avoidance symptoms, and I think when we look at all the ways that folks would like to avoid, and looking at the ways that everyone who has experienced trauma is trying to cope in some way, consciously or unconsciously. And if we could look at our language around that, right, that the ways that folks avoid and cope with and survive are varied and don't always look so great. They're not always the healthiest things, right? When we talk about sexual risk-taking for survivors of child sexual abuse, they end up in situations where you're often re-victimized because of the vulnerability. It doesn't cause the sexual assault, but it definitely causes a higher level of vulnerability. So looking at that, trying to avoid, trying to step away from the memories or reminders, that we look at how people self-medicate and call it attempts at coping, attempts at adaptation, and that the language we use will allow folks to open up to us and actually talk about something that could lead to changing it. But if we're always, well, that's bad, that's the wrong thing to do, you've got to stop, and we're labeling things as, these symptoms and with very negative terminology, instead of maybe saying, it sounds like you were trying to do the best you could in a horrible situation, and you were creative and you were smart and you were able to survive it. But now it sounds like maybe some of those ways that you've coped and survived are actually maybe adding to some of the difficulties you're having. Let's talk about if there are some alternatives that we might try out together, and let's figure out how we get you support as you're trying out those new ideas. And I think that's one of the ways that I've been able to talk to folks who were very, very resistant, even about disclosing that they had any symptoms, especially if they were psychotic symptoms, if they were, there was some delusional content, if they were hearing voices, and those sorts of things. But being able to talk about it in terms of avoiding bad memories and experiences, most of the time, if you're talking to someone who has psychiatric symptoms, the statistics say that we have, enough to go on that there's a very, very high risk. In fact, the two medical specializations in terms for MDs, for physicians, that have the highest rates of malpractice due to sexual assault and sexual impropriety. Any guesses? Psychiatrists are highest, yes. And second, anyone? Pediatricians, right? So that is something that says to us that those of us in this room, we all are looking at, in terms of child abuse and domestic violence and the sexual violence that goes on, in intimate partner violence, and that it's really important for us to see how many ways folks are vulnerable in all of the spheres, even when they're trying to get help. When we talk about, some of the things that are, somatic disorders or where symptoms are primarily talked about in the body, one thing is that we know that can be cultural. That can be a way to talk about something that's emotionally painful, but you don't really have the words for it. We know that kids do that all the time, right? The tummy ache or the headache or just I don't feel good can often mean I'm hurting inside emotionally, but we don't have the language or the concepts around that emotional pain to talk about it. And we see this very much with somatization and also conversion disorders. And I know they're not talked about much, but they are very common, particular to two types of trauma survivors, and that is child abuse survivors and survivors of torture. And specifically, those diagnoses are even more common when those child abuse survivors or torture survivors, it includes some form of sexual abuse or sexualized torture. We know that there's an intensified traumatic response from those. And in terms of conversion disorders, have folks read I Know Why the Caged Bird Sings by Maya Angelou? She basically went through what is called a conversion disorder, that after she was brutally raped by a stepfather, she stopped speaking, and what people have called selective mutism or things like that. She stopped speaking literally for a number of years, and that is what is called a conversion disorder. We have folks who go into paralysis, and basically it's called, a somatoform disorder when we can't find a medical explanation for it. And so these are things where you see folks, in hospitals and they're malingering and they're saying there's some physical problem, but there's nothing we can find, that we do need to start doing trauma assessments when we see these other diagnoses. And that is where we can step in and actually many times make such an impact. One of the very good news about doing trauma work with folks who have psychiatric symptoms of any level is that if we decrease the impact of the trauma, if we start to process that, if we help that person walk through those memories in a safe way and make a connection and show that there's the possibility of support and support won't drop away, that we know that psychiatric symptoms also decrease. And I've seen this time and time again with some folks that had very, very severe symptoms. And I'll just tell a short story about a woman that I worked with in the hospital, and she was diagnosed with schizophrenia. She had many delusions and was out of reality a good bit of the time. She heard voices. She also had dissociative identity disorder. At that time it was called MPD still, multiple personalities. And so she was one of my 12 clients that I was dealing with there as a bachelor's degree counselor at a locked facility. And one day when I got onto the floor, you had to go through a number of checks and doors that slammed behind you to get onto the floor. And she ran up to me and told me that she had been sexually assaulted. And it just blew me away, because I thought, you're locked in here, that means it's someone who had access to you, right? So someone allowed another patient into your room, it was staff, what are we going to do? So we had her checked out and went through a doctor that examined her at the time. We started doing some counseling around it. We had our charge nurse, who I loved, sat outside her room on a one-on-one for nights after that. But each day when I got to work in the morning, she would come up to me and say that the rape had happened again. And for a lot of the staff, as soon as that happened, they said, oh, delusion, whatever. Okay, she said it happened again. The nurse was outside her door, so now we know it's just a delusion. Case closed, it's all over. But she and I kept talking about it. And she continued to come to me in the morning and tell me about the fact that this person was coming into her room and that they were raping her and that they were leaving objects inside her. And that was why we had rushed her to the doctor, because she said she felt like something was still there, that she could feel it. And so as we continued to work, what came out was that we worked during the times when she was more in reality, when she was having better days, and we started to talk. And I never totally figured out exactly who, but what we could get to the bottom of is that her room as a child, her bed as a child was not safe, and that someone did come in and sexually assault her almost every night as a child, and that they did use objects and that they did hurt her, and that probably a lot of what she was talking about could have started to blend with delusional content, but a lot of it was flashbacks and were body flashbacks and sensory memories of the lack of safety she had had all her life. And because no one had talked about that, because there was no trauma assessment in all of these mental health institutions she had been to, then this was a person who it just started to kind of come up, bubble up, because she needed to deal with it. And we were able to do a lot of work. And in that process, actually one of the alters that she had, who was a raging male alter that she called by the name of Jim, went away. And we never saw Jim again. And her kind of times when she'd be just responding to internal stimuli and not really in reality, that decreased quite a bit after we were able to take those times to talk about, it wasn't okay that you weren't safe. And it's not right for someone to come in and do this to you and for you to feel scared all the time. It's not okay that your body was hurt. And even though we worked kind of through some of those simple core issues, that made a tremendous difference. And so I think I want to be able to convey to you that those are the things that we can make an impact, even if it's that phone call, that short phone call. And we often have that knee-jerk reaction to kind of, send someone somewhere else because, oh, I can't deal with that. This is too big, or it's going to be too long-term, or, it doesn't fit our services. And while we absolutely should all know our limits, we can't be everything to everyone. I always think it's better to be a specialist than a generalist, and then to work with other specialists so that we can, help each other and work as a team. That means more support for folks. But I think we can, really just build our own confidence about how we can work with this population. A couple things I wanted to say in terms of that story and psychotic disorders and trauma, and I think those are the scariest, right? That if someone is responding to internal stimuli, they're hearing voices, there's delusional content in what they're telling us, something sounds so odd or so strange, is to know that a lot of times those are intrusive thoughts, that they're flashbacks, and that the psychotic symptoms start to sometimes overlap with those stories of violation, right? Because if you weren't able to tell that story of violation, you were silenced, which we know is a huge piece and another part of the abuse, that abusers want to make sure you're silent. And I think the community of folks with psychiatric or mental health disabilities are silenced even more because we say, well, we can't believe you. You can't be an accurate historian on anything. If you have one delusion or if your mood's swinging, then, you probably aren't telling the truth or you're making it up to get attention. And I think we do have to check in with some of the bias that's out there and the stigma, and really look at, is that true? That would we say, to someone who, has diabetes, well, you're so weak, my goodness, why are you needing to go and, change different things and talk to people about it and take that medication? Why don't you just strengthen yourself and think your pancreas stronger? What's wrong with you that you're not making enough insulin, But we don't do that to people that have diabetes. But we do that to folks who have brain disorders, right? And then we're talking about chemical brain disorders, and that is a really important thing for us to remember, that some of our assumptions about that, even though, of course, brain disorders impact thoughts and feelings and behaviors, often, far more than diabetes, but it is important for us to think of it in similar terms as something that is impacting that person's life. One of a few things, and like I said, it could be a long list about looking at use of alcohol and other drugs and even prescription medication and over-the-counter medication, that it is so difficult for folks to remain sober after a trauma, and that this really is about self-medicating. Oftentimes the assessment and the treatment is very, very complicated for folks with psychiatric disabilities who have also been self-medicating with drugs and alcohol, and we know there's a high rate of that. And sometimes because of the ways that we need to help folks remain sober and need to have those rigid rules and need to have more directive therapies in drug and alcohol programs, we kind of bump up against the fact that it's sort of at odds with the type of empowerment, self-directed, very gentle, client-centered therapy that I have found works best with trauma survivors. And so you're kind of at odds when you're working with a trauma survivor who also has drug and alcohol addiction issues. And I would say, you know, what we can do is to help folks navigate that, right? We don't have to be the specialist in both or either or, and if we are the specialist in one, all the better, but we can help people navigate that system to use what works. And I think, you know, oftentimes when people are after a trauma, especially with interpersonal violence, they're trying to build a sense that they have the right to boundaries. And so navigating sponsor relationships can be very hard. Navigating relationships with us as helpers, right? We have to be sure of our boundaries and think about the fact that we can't be rescuers or that we can't be so cold and distant because we're afraid of someone with a mental illness. And so looking at boundaries is a big piece of doing this work. And also that we need to be really careful around addiction work of the stuff that says, the fourth step, that says, you know, you have to take responsibility, clean up your side of the street, what was your role in it? And what I ask of folks who are working in addiction work who are survivors of sexual violence and domestic violence is that they work with a sponsor who will allow them to skip that fourth step in terms of the abuse and violation. That is not to be spoken of in a fourth step ever, because it was never their fault. There's nothing they could have done or been or at any point in their life that could have caused or where they had a role in that victimization. And if you can get clear with that, maybe if you can have influence with folks who are doing the addiction work or build a collaborative, of course, with a release of information and respecting the privacy and the confidentiality of your clients, of course. But if you can do that work collaboratively and talk with folks who are doing that work, then we can have a tremendous impact so that there's not that re-traumatization, right, and that re-victimization, those feelings of self-blame. What I have seen is as long as the self-blame is there, the trauma symptoms are up, and as long as the trauma symptoms are really up, then all of those other mental health symptoms will be exaggerated as well. I wanted to, in just a moment, I have a brief role play that I'm going to need some volunteers, so start thinking about that. All you have to do is read something off of a card. I will need 12 people to participate. But I wanted to mention that I really feel, and I'm, you know, out there saying this to everyone, we need a different diagnosis or at least a way to talk about complex and chronic trauma. And the ways we talk about it now are basically throwbacks to when we, you know, threw women in asylums and said that they were hysterical. And those diagnoses are borderline personality disorder and dissociative disorder. And not to say that there are not folks who have the symptoms that match up with those disorders, but I think the cluster there of the symptoms that we're talking about really absolutely relate to chronic trauma, complex trauma. And I'll outline a few of them. The biggest one for borderline is avoidance of abandonment, right? And what do we know about child abuse survivors and that most sexual violence survivors, it's someone that you know 80 to 90% of the time. And if you have any sort of disability, including psychiatric disabilities, it's about 96% of the time you will know the perpetrator. So avoidance of abandonment, we know that kids and folks that are abused by their intimate partners, oftentimes the only person you have to cling to after that or to turn back to as your confidant or who's told you they're the only person you can because they've isolated you from everyone, right, is that avoidance of being abandoned even by that abuser, right? And that confusion of this person's hurting me, but I also love them. So that sounds a lot like what borderline personality disorder has been made out to be. Also having unstable relationships. Well, what do you have to model it on if you're a trauma survivor, an abuse survivor? What sort of stable relationship where there's mutuality and respect and love and those sorts of things have you maybe even experienced? And we know that most of the people who are diagnosed borderline have had some sort of child abuse. At least I think that's often well known, but I think we need to start to look at the fact that this is really chronic and complex trauma, that identity issues, and that's with all the personality disorders, but specifically with borderline, identity issues, that lack of a solid self, the chronic feeling of emptiness, that's there. Oftentimes that is because there wasn't that safe holding environment to build that sense of self. And the impulse control problems, right? We're looking at the fact of brain development being so different, and one of the chemicals specifically, which is, it's called wait, I'm gonna get it wrong. I have it written down and now I lost it. It is called oxytocin, not Oxycontin, that's a drug. Oxytocin is actually one of the most dramatically impacted brain chemicals, and it is often secreted to control impulses, to help in the decision-making process, especially around sex drive and libido. And we see with borderline personality disorder in that diagnosis a lot of high-risk sexual acting out, reckless kind of risk-taking, and those sorts of things, and a lot of mood swings and mood lability based on relationships. Well, if you've never had that sense of, I'm worth being loved and I have the right to and to be able to expect stable relationships and that people will stick around and it'll be safe, then that risk-taking and that mood lability, of course, is going to be there. And we know that with trauma as well, right? That the ups and downs, that sort of abnormal amount of stress that someone is reacting to is really normal in that case, right? And that's the very meaning of the diagnosis of trauma, is a normal reaction to an abnormal amount of stress. So I wanted to just kind of leave in terms of that, thinking about chronic and complex trauma, that the folks that we kind of feel put off by, that we feel are resistant or are hard to work with, that we look at how their reactions to us, their angry outbursts, that we talk about having temper problems or irrational anger, that many, many survivors of trauma, and I would say all, have valid reason for that rage, and that if we can find a safe way to allow that to come out, to offer that we understand that that rage is valid, that many times we don't have to have this push-pull relationship that we do, or start off with, oh, this is a borderline, so set up all the boundaries, we make extra special rules for them, and end up being so. And we do, right? I mean, that's like, and we say, oh, they can't call us. There's only this many messages per month. You can't do this. If you have a suicide attempt, I actually won't talk to you for a week. These are things that in borderline programs people go through. So we end up being more harsh and critical and setting actually overdone boundaries, which are sometimes punishing with folks who are survivors of very complex and chronic long-term trauma. So if we look at some of those things we'll help ourselves find a way to work with folks in a more appropriate way. So I do need those volunteers to take just a moment and go through a quick role play, and then that will get us thinking about how we want to react to a survivor with psychiatric disabilities. Like I said, each of you will get a card, and you're just going to read a sentence or two off of that card. And if you would come right up here, so just stand on up and walk up to the front. Need a few more. I promise it's painless, no acting or improvisational skill is necessary. And while a few more people are coming up, I'm just going to ask permission for a couple of the roles, if someone would be willing to play the survivor, and if someone would be willing to play the rapist. So if you would, each of you are going to be responding to the survivor in the role play. And Grady here has been nice enough to play the survivor. What we're going to do is have you turn to each of the people in your support system, starting down there with Mary. I do have 3 more cards. I would love to have someone play those roles. It's important that we see the whole thing. And our survivor is going to have a series of strings here. One will be connected to each of the people that are in the support system. So if you'll come on around in a half circle kind of, and each of you get a string. Thank you. Okay. And if you will start right here and go around the circle, and then end with the woman right here in the black. And then each time, correct, yes. And when she discloses to you, you'll tell us who you are on the back of your card and read your response.
Joe raped me and now he has the FBI tracking me. Can you help me?
I'm a shelter worker. I'm sorry, we can't let you in the shelter if you take any medications. You might give them to other clients, and we don't have a doctor here for you.
Joe raped me and now he has the FBI tracking me. Can you help me?
I'm your brother. You know I'm always there for you, sis. But I'm not going to listen if you're going to talk about the FBI again. That's all in your head.
Joe raped me and now he has the FBI tracking me. Can you help me?
Hotline counselor. This is a rape hotline. I can't help you with those things. I need to keep the line open. Here's a number to Long Beach Mental Health.
Joe raped me and now he has the FBI tracking me. Can you help me?
I'm the forensic nurse. How long have you been homeless? Are you on any substances or alcohol?
Joe raped me and now he has the FBI tracking me. Can you help me?
I'm the psychiatrist. How are your meds working for you? I think we need to increase the dosage. You are very agitated. Here's the prescription. See you next month.
Joe raped me and now he has the FBI tracking me. Can you help me?
I'm the therapist. You have to learn to be assertive and set clear sexual limits. I know you have a hard time with that. Let's talk more about your self-esteem.
Joe raped me and now he has the FBI tracking me. Can you help me?
I'm your parent. What were you doing outside the board and care home? Are you taking your medication? I told you, you are not ready to have sex.
Joe raped me and now he has the FBI tracking me. Can you help me?
I'm the police officer. Ma'am, you need to calm down or I'm going to have to 5150 you.
Joe raped me and now he has the FBI tracking me. Can you help me?
I'm your friend. Susie, you're acting funny again. Are you taking your meds?
Joe raped me and now he has the FBI tracking me. Can you help me?
Remember, we agreed one of your goals is not talking about the FBI anymore. If you keep it up, you'll lose your outing privileges. I'm your case manager.
I'm Joe. See, I told you no one believed you. You're crazy.
And who is she left tethered to? Joe, right? So what if Joe is an intimate partner or someone that she lives with, someone at the board and care, right? And most likely, 96% of the time, someone with a psychiatric disability is going to know the person who sexually assaults them. Okay? Thank you very, very much. Thank you. So, absolutely, we know that none of us in this room ever says any of these things, right? These are totally taken from outside people who, you know. They are, unfortunately, some of them are quotes, and many of the times when they were said to the survivor, I was in the room, or they were told to me by so many survivors that I put them as part of the role play. So these are mostly quotes or repeated quotes that survivors have told me that they are running into when they're trying to report whether it's sexual violence, whether it's a teen who's trying to report that they've been sexually assaulted, whether it's, you know, intimate partner violence that they're talking about. What were the things that we thought came up? What sort of myths around whether mental health or around sexual assault or the process or how someone would disclose? What are the things that came up? Anyone? Yes. absolutely. Yep. Oh, that's weird. And I've just focused on that piece. Yeah. So that's a big part of what we see. Yes. Lots of blaming. Yeah, definitely. Which we see in general, right? With interpersonal violence, we definitely see that it's easier to blame the victim, and that people, because of myths, have that mentality anyway, but especially with this. Yes. Yes. Disconnect in services and linkages, and a disconnect in the support. Yes. Lack of understanding of what rape is, right? You're not ready to have sex. Yeah, and I think that's a big piece of watching our own language, right? That when someone is telling us about, even if, someone is saying, well, I had sex with this person because, and it was survival sex, we can see that it was about being able to survive on the streets. And when I volunteer in a homeless program, one of the things that we do here is that to survive on the streets as a woman, especially with psychiatric illness, that you must either get someone that you basically, stay with, and I would call that a pimp, who uses you and or sells you to other people, or you can just be raped almost on a nightly basis by anyone who comes along. And so the known perpetrator is often better than the unknown, right? Yeah. Yes. Yes, lots of stereotyping, definitely. Absolutely, yes. Let's fix that weird thought you're having, right? Or just fix it in general, right? That being listened to is huge. And, that we know there is an amazing amount of healing that happens just from allowing someone to tell their story, right? And if that story has sections in it or pieces that sound strange or that we know are out of reality or that don't make sense to us, that the piece we can listen to is, you know what? This person is telling me about pain, about violation, about a traumatic experience, about being abused. And all we have to do is respond to that part, right? And know that if there are this delusional content, that we don't have to respond to that, right? That the feelings are real. That the feeling of, not only have I been raped, but now I believe that this person has the FBI tracking me, right? Which would be totally scary, right? That fear, that terror is real. And all we have to do is respond to the feelings. We don't have to say, oh, well, this other part's weird, but okay, I'll listen to you about the rape. We can just leave that piece alone. We're not going to argue someone out or, critical think someone out of believing their delusion, right? Absolutely, yes. And so what I'm saying in terms of not responding to it is that we don't need to argue someone out of it, tell them oh, that couldn't happen, that's all in your head, don't say that anymore. That we do need to look into that because abusers' level of manipulation and deception is so profound that we need to make sure of what we know. And that's a comment I want to make in terms of the fact that many times what we're looking at is we're dealing with maybe a ritual abuse survivor, right? And the things that we will hear, we need to be able to believe and hear the unbelievable, the unthinkable. When we do this work. And if we have some limit like, oh, well, if it was that bad, well, that's weird. Nobody would be able to do that. I can't imagine it. There will be the unimaginable that you will hear. And so we need to be prepared for that. And we need to be prepared to hear the level of manipulation and deception that abusers are willing to use. Do we think that the survivor that it's realistic that the survivor would have disclosed that many times? No. What would have happened? Stopped. Absolutely, absolutely. And so that is what I really want to, if I can convey one thing today about being helpful in our responses for survivors with mental health disabilities, it is that that first reaction, and that is something that I hear about when I have survivors walk through my door that, are, 60, 70 years old, and they're saying, this is the first time since that one time that I've ever told anyone about this. It is because that one time or that 2 times, or then I tried again about 10 years later, and then I tried in my 20s, and then I tried, because those times were so difficult, because that it caused secondary trauma, and they had to shut down again and be silent just like the abuser said they would, right? Because the other piece that's used is the stigma of the psychiatric illness. No one will believe you because we all know you're crazy. I've already told everybody how crazy you are. Look at you, you take meds, and I'm going to tell everybody that you do and that you have to go talk to a shrink, right? The society is already so ready to stigmatize that, and then the abuser will make sure that that's out there, that if someone comes to help, they'll intervene and make sure that you know that person is crazy. So it's really important in terms of how much power we have, and it can go one way or the other, but what we know is that the first person or that disclosure that's happening has the biggest impact on the long-term healing process of trauma survivors. And that really means the length and the time it takes and the process, because I can say in terms of my work that part of the time we work on the actual abuse and the trauma, and then we work on, of course, the manipulation and the deception and all of that happened. But then we start to work on, and sometimes even for a longer period, all the people that weren't there, all the people that denied it, didn't believe it, shut me down, told me I was crazy, didn't want to believe that so-and-so, Joe, no, that it couldn't be, right? And so we can have a really huge impact on actually decreasing a lot of that trauma and speeding that process for folks so that telling and trusting again and knowing that someone believes and knowing that someone can respond despite something that sounds strange to us can have such a tremendous and healing impact. So I would say kind of, and leaving a few minutes for questions if we can, that know that of course we want to establish safety and rapport, and this may take longer, right? It's about also being patient, and that's a reasonable accommodation, that we may have to work a little more to gain trust. We have to watch our language. We have to think about what it means to be an ally to a population that is used to being ridiculed, isolated, ignored, treated as invisible. And so what that would feel like then to walk in the door one more time and tell one more person this story that is painful and horrible to have to recall, and have one more time the bad examples that we saw up here, right? And so I hope we'll keep in mind that we don't want to sound like this, right? I know that's in our hearts if we're doing this work anyway. But sometimes, we're bombarded with a lot of messages about who folks are that have psychiatric illness, about who are the people that have addictions, about, who are the folks that are homeless. And we know that those things really just mean vulnerability. They don't cause the abuse. That we need to explore and validate the problem and those feelings, and figure out what it is this person is seeking. As Grady said, it could be about just somebody to listen, right? To finally listen, hear my story, and to allow that to unfold in their own time. And that we know that, if we're going through our regular process, that we can be, helpful in not immediately using kind of psychiatric jargon and diagnosing, not immediately referring for medication, and that actually, according to, our Americans with Disabilities Act and fair housing and all those sorts of things, our programs really do need to be accessible, and that includes to folks with mental health disabilities. So we want to look into our intake procedures, how we're connecting with people. Is it in a positive way that will make sure that we give equitable services to everyone, and to remember the very strong positive impact that we can have in listening to and believing and being very gentle with survivors, all survivors, but those with psychiatric disabilities. In the end, that's going to have a huge impact on their process of healing. So thank you very much.
Thank you, Tiombe. And I also want to acknowledge this morning that Tiombe's mom is here with us this morning. So welcome. Thank you. We do have just a couple minutes for questions. I also just wanted to add, because I was busy up front, we didn't have time to do the round the table stuff this morning, but if people have brief announcements that they want to make, sort of in between question time or whatever, we can do that. And I need to introduce you to Kathleen, who's sitting 4 people behind you. Okay, so questions and or brief announcements, yes.
Yes. I do. It's definitely a problem in terms of when you have that short period of time. What we know, though, is even very brief crisis intervention that's focused on some of those key elements of helping reduce self-blame, validate that the trauma could be a part of what they're experiencing in terms of exacerbating symptoms, and what they're going through, the difficulties in self-care, and when we're able to give that bit of kind of psychoeducation about trauma and how it impacts a person, often we may open a door to allow for some crisis intervention around ways of coping with it, right? So dealing with it. I even just work with, using handouts when you just have a few brief sessions with someone, a handout on what trauma is, and maybe very specific to different types, whether it's a child abuse survivor or an intimate partner violence survivor or a sexual assault survivor, and what those specific things they might experience, what trauma is, that it's a normal reaction to an abnormal amount of stress, that it's not your fault, that those are huge concepts that we can convey, and if we convey them with everybody that they're seeing in those few days, it makes a tremendous impact. A lot of folks say that, especially for interpersonal violence trauma, and I've seen this in the rape crisis centers, within 3 to 5 sessions or 3 to 5 contacts with folks who all convey that same non-judgmental, it's not your fault message, this is what trauma is, you're responding normally, we understand why you're having difficulties, how can we help, how can we brainstorm some ideas, that you see a drastic decrease in trauma symptoms. Yeah, yes.
A lot of what you say resonates with my practice, especially with high functioning clients and private practice.
Yes.
I also have this role of being a supervisor and a therapist within an agency, nonprofit, and there I come across clients that are much more low functioning.
Yes.
And also there's more complication with DCFS involvement, with the trauma, victim, sort of having children and not being able to take care of them sufficiently so that the department's involved. But the mental health service providers are sort of asked to, give out the diagnosis that may be of detriment to the client, and there's a lot of judgment.
Yes.
I would think, I would feel that it's coming from the department towards clients. And do you have any thoughts or any recommendations on how to navigate the clients in that situation? Because oftentimes these clients get their kids home.
Yes.
And not
A huge problem and question. I would say, a lot of it is that, building rapport and relationships with folks across those agencies so that we're doing cross-training and so that we're talking to one another about, we have a client base that often has very severe, mental health and psychiatric symptoms, and, when they're having their kids taken away, we're really in this place of, could we get them to a better place? Can there be some reunification and working together towards that? And I find that if I have relationships with folks first, they're more willing to listen to what I have to say about what's happening with that client and understanding it versus just kind of the label and not seeing the person. Because I think that does happen. We all do that to a certain extent, but building those relationships and doing a lot of cross-training is very needed, right? So that we don't kind of see one another at cross purposes. We may have different roles that we have to play, right, and different responsibilities, but it doesn't mean we have to be at cross purposes.
Okay, well, please join me in thanking Tiombe so much.